Hello, my name is Miles Brown. Welcome to my OMED 1362 presentation. It will investigate the psychosocial issues that people living with heart failure can face. I will relate my findings to a patient I've seen on placement to help contextualise my findings and determine if the area someone lives in contributes to their subsequent way of life. My chosen location is Swale. It's a coastal region with a mix of urban and rural areas. There are approximately 146,000 people living in Swale, 28,000 of which are 65 and over. The average life expectancy of 80 years old falls short of Kent's average, with 23% of which caused by circulatory disease. So my case study involves someone I saw whilst out of a local ambulance trust, where the patient was living with heart failure. It was an elderly patient living alone with poor mobility and used a frame to get around. He said he felt quite down that he doesn't have much social interaction due to his mobility and struggles getting up his stairs. So heart failure is the inability of the heart to adequately pump blood around the body. It's perceived as the end result of preceding diseases, including but not limited to ischemic heart disease, valve dysfunction, and hypertension. The most common signs and symptoms are noted as progressive fatigue, dyspnea, and peripheral edema. So according to recent figures, 530,000 people in the UK were diagnosed with heart failure, with the average age of sufferers being 78 nationally. The prevalence in Swale, more specifically, was reported as 951 people. Unfortunately, there is no cure for heart failure, so treatments predominantly aim to reduce the symptoms. These can range from medications aimed at slowing the heart rate and reducing blood pressure, to changes in diet and exercise. Surgery can be performed if non-invasive options would be ineffective. Policies surrounding heart failure focus predominantly on preventing risk factors. For example, Change for Life attempts to reduce obesity by educating the public on nutrition. The NHS Smoke-Free campaign has also been successful in reducing the number of smokers, evidenced by 37% of people using stop smoking services quitting completely. Other initiatives include NHS free health checks for people aged 40 to 74 and Heart Age Tool, both aim to gauge an idea of your health and identify areas of concern. Public Health England and the British Heart Foundation have also partnered to develop local community practices to improve the prevention and management of heart disease. But are these initiatives enough? What about other factors that affect heart failure? For example, sociological issues. According to research, those who have low socioeconomic status have an increased risk of conforming to behaviours that cause ill health. This is supported by Hawkins et al., where they state those that live with low socioeconomic status are much less compliant with lifestyle changes including diet, exercise, and taking medication. It also highlights other struggles including limited access to healthcare services, transport costs, inequalities in treatment, and decreased social support, which all decrease the quality of life and increase hospital readmission rates. So going by this research, the patient I visited is disadvantaged given Swale featured in the top 10% most deprived areas nationally, with high prevalence of cardiovascular risk factors. In line with this, it's worth drawing attention to the quote, "If you're born poor, you will die an average 9 years earlier than others." This is supported by statistics which state the life expectancy in the richest areas of the UK is 83 years old and 75 in the poorest. Research also suggests living in low socioeconomic areas such as Swale reduces social activity, which contributes greatly to increasing the risk of mental health issues. From back when 2016 states depression is present in around 1 in 5 of heart failure patients. These patients are reported to have a decreased quality of life, use healthcare services less, have an increased readmission to hospital rate, and a twofold increase in mortality. Furthermore, anxiety in heart failure patients is said to be around 40%. A study by Mahoney Davis et al. Gathered experiences from heart failure patients where the quotes on this slide demonstrate not only the physical and emotional impact heart failure has on the patients themselves, but also clarifies the social impact it has regarding friends and family and how the patients may become isolated without any support. So what are some pathways available to heart failure patients? So Cardiac Rehabilitation Centres are one clinical pathway. The local centre for Swale is Medway Community Healthcare, consisting of multidisciplinary teams of nurses, physios, counsellors and exercise therapists, which aim to improve quality of life through diet, exercise and help with psychological issues. They are also able to provide home visits, thereby expanding their reach to those with poor mobility, such as the patient I encountered. 2015 to 16 figures show these have helped 12% of patients stop smoking, increased participation in exercise from 40 to 70%, and depression was also reduced by 5%, which demonstrate the success of these centres. A non-clinical pathway are heart failure support groups that run activities such as exercise classes, coffee mornings, guest speakers and day trips. A study by Lockhart et al. Confirmed the benefits of these groups, stating many felt valued being part of a group where they felt understood and could share experiences. Many are developing friendships which gave them a renewed enthusiasm to improve their life and take better care of themselves. However, given the poor mobility, it could prove a struggle for my patient to get to Medway, which is the most local group to Swale. This highlights the need for more support groups to open and expand their support to those who would otherwise miss out due to travel issues. Okay, so going forward, Franklin et al. Highlight that medications, whilst crucial, don't tackle the root cause of heart disease, such as diet, smoking and physical inactivity. Similarly, the psychosocial needs of the patient must also be highly regarded, especially as these contain many intertwined components that inadvertently complement each other and lead to a poorer prognosis for patients. In that, poverty is said to breed ill health behaviours and contributes to psychosocial issues which lead to increased hospital admission rates and premature deaths. Therefore, it's vital to tackle these more proximal causes of cardiovascular diseases in deprived areas such as Swale, as the evidence strongly suggests that the area you live in does in fact play a huge role in determining your level of health and quality of life, especially with heart failure. Thank you for listening. This is my reference list and the second page.